at home watching this, so we good. So, Carlton, the floor is yours.
Thank you so much. Thank you so much. And welcome, everyone. Everyone is coming into the room, as they say. They're coming into the room. And we welcome you one and all. We're going to give just another minute for folks to kind of pop in. And we are excited. This is our second training session with the great state of Louisiana. I understand that. Good morning, my friend. I understand that you are all dealing with some weather or potentially dealing with some weather, depending on where in the state you happen to be. So we're going to let a couple of folks kind of jump in here and pop in here. But we have a great conversation that we have in store for you all today. And we are looking forward to kind of building upon the conversation that we had the first go around. And so if you all don't mind, I'm going to do what they do on these Zoom things and share my screen so that we might be able to get off to a bit of an official start. And here we go. So welcome, one and all, welcome again. And my name is Carl. Stop. My name is Carlton Hall, and I am very grateful to have this opportunity to be with you all today to share with you all a conversation that we all think is vitally important, going upstream, digging deeper, and really, what does that mean in terms of the role that many of you play in coalitions, particularly with how the nation and specifically your state is addressing and looking at the impact. My computer is really dealing with me today. The impact of the opioid and heroin crisis. Forgive me, everybody. I'm just trying to deal with some technical issues here. So grateful to be able to have share this opportunity with you all. I am grateful to be able to have the opportunity of working with my partner in this endeavor, Dave Clausen. Dave is the director of the Mid-America Prevention Technology Transfer Center. He oversees a consulting firm, and it's in that capacity that he works and partners with us here at CHC to be able to provide some really necessary and important help in supporting our ability to deliver these things on a virtual basis. And so with that, Dave, if you wouldn't mind, I just would like to do just a little bit of check-in and make sure that folks are going to be able to engage with us throughout this training. Could you just kind of share with everyone what's expected in terms of our hope and support that they will be able to work with us in the chat and other functions?
Yes, absolutely. Hello, everybody. And Carlton, you said it, partnership. Because, you know, what we both believe, prevention is better together, and together we are stronger. So just a real quick Zoom tour to kick things off. We've all been in this pandemic world for a while, but just want to make sure we're all kind of same footing when it comes to engaging in today's session. If you look at the bottom left-hand corner of your screen, for those on a computer, you'll see the mute, unmute button. For the majority of the session, we'd ask that you do stay muted, but throughout, Stephanie will be asking for you to come off of mute and engage with us. Then next to that is the stop and start video button. Moving along to the right across the bottom, there's a participant list that will show you who is here in the room with us when you click that. Next to that is the chat button. When you press that, you'll have the chat box pop up in the bottom right-hand corner of your screen, and that's where Carlton and I will be hanging out for the majority of this session today. And I see some of y'all are already in there. Good to go. You can consider it okay to talk during class in the chat box. Then also you've got that button that says reactions. You can give us a thumbs up, a high five, a slow down, a go faster as well. Then two last little things I just wanted to call your attention to. If you look towards the top right, it'll show speaker view or gallery view. That's how you can change the layout on your screen to change how big the slides are and to be able to see everybody's webcams. Feel free to play around with that and find the view that you like best. Lastly, on the very top of the screen, it says you are viewing Carlton Hall's screen. There's a little drop-down arrow there that says View Options. When you click that, it will give you a menu that says annotate. We will be using the annotate feature a little bit later today. And so to do that, you'll click annotate, and then we'll be clicking the stamp feature or text feature. We'll see. Got to keep you on your toes for that one, but also give you a little walkthrough at that as well once we get to that point. All right, that is a quick Zoom tour. And if you have any questions, again, I'll be in that chat box. Send them my way. Carlton, back to you.
Thanks, Dave. And so we know and realize that many of you are familiar with Zoom, but some of us still would, in order to make sure that we're able to engage fully, would want to have that little bit of a background. So I appreciate that. I am so appreciative of those who have made it possible for us to be able to be together. The Department of Health and Behavioral Health and the Louisiana Center for Prevention Resources. These folks care desperately about what it is that you all are doing and working with, are working consistently and trying to make sure that you have the best and latest information possible. And so with that, I'd like to offer an opportunity to Paula or Dr. Harrison. I'm not quite sure who's going to do it, but to provide a bit of a welcome and share why this is important today. And so Paula.
I'm sorry, I was mute.
Okay, there you go.
The Zoom bumps. Good morning. Like Carlton said, my name is Paula Carrero, and I'm the research coordinator for the LCPR. We offer trainings and CEUs to all the prevention professionals all over the state. And these trainings that we are having this morning is part of that series of trainings that we are trying to provide for this year. We really appreciate Carlton and his group to be available to do this training for us this morning. We have all our information about trainings and classes on our website. That is www.subr.edu/LCPR. I will put that on the chat room. Please visit. I encourage you to visit the website. It's very friendly. All the information about trainings, classes are there. Registration links, everything is in there. Feel free to email us at lcpr.edu so you can ask questions and get more information if you have any problems. So saying that, we are going to, Carlton is going to provide the evaluation link for you guys. I encourage you, please fill the evaluation, and we're going to issue our certificates shortly after the training. Okay. When I say shortly, it's not today, but we're gonna send you the certificate. Okay. So if you have any questions, put it in the chat room and we are ready to go. Thank you.
Thanks so much, Paula. I appreciate you and Dr. Harrison for being on board with us. I want to offer our great thanks to everyone that's a part of doing this, and also share with you that as we are conducting this, that the views that will be expressed by either myself or Stephanie Strutner, who I will introduce in just a moment, are those of our own. And while this may be partially funded by resources that are coming from federal resources, they hold no responsibility to the views that we express. They're all our own, so now they are off the hook. With that, I'm going to just really introduce now and take an opportunity to share with you what I'm very excited about. I'm very excited about what you all are going to receive today because the woman that is going to be co-presenting with me is one of my dearest friends and a person that I have extraordinary and inordinate respect for in the work that she has done, not merely for her state, but also across the country. I could speak a lot about who she is, but I want to make sure that I do her justice. So I'm going to share from her biography. She refers to herself as a retired substance use prevention coalition director. That whole retired thing, I'm not quite sure how how truthful that is. Stephanie Strutner owns and operates an independent consulting firm, Catalyst Evaluation Group, through which she provides support to clients through measuring impact and conducting biostatistical and epidemiological analysis. She also serves as consultant and trainer for a number of agencies and serves as part-time CEO for the Prevention Alliance of Tennessee. Stephanie has spoken to the US Congress on a number of occasions on the impact of drug use and that it has on our communities, and has also testified before the Tennessee General Assembly on multiple pertinent prevention issues. In fact, in 2018, she was summoned to a meeting in the West Wing of the White House with the President of the United States to discuss effective opioid prevention strategies in local communities. In 2020, the efforts and impact of the coalition she led were selected to be showcased as a case study to Congress. I want you to know just how grateful I am for her partnership and relationship here, and to share with you that she intends to speak a lot about the epidemiological triad, the discussion around how all this relates to the strategic prevention framework. We're going to deal with how factors lead to those behaviors that we're trying to address, and how successful coalitions align these strategies to their local conditions, and look at some examples of that work. What I want to do is I want to take a moment to talk to you about the context in which all of this is happening and why we think that it is important to be able to do so. As many of you will recall, we have been dealing with a crisis even before the pandemic came upon us, right? The CDC referred to that crisis as a crisis that occurred in 3 waves, right? The first wave dealing with the over prescribing malpractices that had led to a number of overdose deaths as a result of prescription drugs. That wave then turned into a wave where we saw the immediate rise of heroin that began to surface in many of our communities, which has led then into a rise of synthetic opioids, overdose deaths like those of fentanyl. Well, in the last 4 years, we have seen that has dramatically increased. Dr. Nora Volkow, in fact, the director of the National Institute on Drug Abuse, has indicated that the rise in fentanyl has really exceeded things to a far deeper level than we might imagine. Fentanyl, as many of you know, are 50 times higher in potency than heroin, a lot because it affects the brain much more directly, and has a way of interfering in the resuscitation process and depression that occurs, which gets in the way a lot of times of even the resuscitation medications such as naloxone might be able to hold. And that's part of the reason why we're addressing this. But one of the things that I want to illustrate here for you is that while you see that orange line of fentanyl occurring, what I want to point you to is that we are also dealing with, in these later times, the increase of these psycho stimulants that are also occurring. And if you actually look at the actual numbers of these, what you will note is that the deaths that are occurring as a result of these psychostimulants are equal to the number of deaths that are occurring from the rise in fentanyl. And so this, I would suggest, represents a 4th wave that we are addressing and dealing with here in our nation that we have to be attentive to with respect to our work as coalitions. This is no stranger to those of you in your great state. You know, of course, that you are indeed dealing with those rising deaths that are occurring as well from opioid misuse. But merely looking at the number of opioid deaths, I think, is problematic, because if you go through a further look of what's taking place in your great state, the number of overall deaths that are drug involved exceeding 1,400 in 2019, represents 898 deaths that I would suggest are occurring as a result of polysubstance misuse. And so by exclusively focusing merely on the opioid crisis, you might be missing some deeper issues and challenges that I think will require us and should require us to go a bit more upstream and to dig a bit deeper, as we intend to do today. You're looking here at the sign of the rise of those synthetic opioids that are really causing problematics, as represented by the gold line that you see there and the black line that you see there, that is taking place in your state. And COVID-19 is the context in which all of this is taking place now in your state. That context of the pandemic has been now quantified. We now know that in those first months that we were dealing with COVID-19 and responding to the pandemic, we saw overdose increases up to 42% per month as a result of that. The clear notion to understand here is that that rise in overdoses that were occurring during that time frame is not occurring in a vacuum. It was indeed occurring as a result of signs that we had seen earlier. Because of the increasing numbers of those that were representing co-occurring disorders of substance use disorder, as well as serious mental health incidents that were taking place. And so the combination of that in the context of the pandemic are things that represent what I believe Dr. King was referring to when he shared that there is a fierce urgency. And I think that there is some relationship to that phrase and where we stand now as a society and as coalition leaders. And so as such, that fierce urgency requires us to think much more critically about where we are, what is it that we're trying to do, and how do we address it. And in that mind, we are going to ask my friend Stephanie to come on and share with us what are the implications of these issues with respect to coalitions and how coalitions should think critically about that. And with that, I'm going to stop sharing my screen and say thank you to you all for your wonderful attention. And Stephanie, I am turning it over to you to take us into this.
Thank you, Carlton, and good morning, everybody in Louisiana. Usually when I speak to people, I have to define what y'all means, because when I talk about prevention, I get real excited, and y'all is an endearing term where I live. I feel like maybe I don't have to really define that for you guys, but y'all, just in case, is a collective group of people, and it's an endearing term where I live. So now you'll know. And so we're going to get into really thinking about the epidemiologic triad and how that connects to prevention. And I encourage you to put on your seatbelts because we've got a lot of stuff to cover. We're going to move pretty fast today. And so when we think about the epidemiologic triad, the term may be new to you. However, the content probably is not, because all we're talking about is this concept where we have the triangular approach between the agent, the host, and the environment. And so pre-pandemic, I usually had to provide a definition when I introduced myself and my title to people as an epidemiologist. Now, post-pandemic, most people know what an epidemiologist is, but translation, please, let's put this in layman's terms to talk about our agent, our host, and our environment. So in our position as preventionists in substance use prevention, our agent is going to be that drug. Our host is going to be the person at risk to engage in a particular behavior, typically one that you all are trying to prevent. And the environment simply is where they are. So typically in the community. And so our vector really is going to be this act of substance use. And so I want to just start from that very foundational piece and introduce this concept to you. And so Dave mentioned that we would have the ability to use some annotate. So what I'd like for you to do here is think about the epidemiologic triad. So you've got your agent, your host, and your environment. And what I'd like for you to do is, if you can start the annotate. So at the top of your screen, click on the annotate tab, and you can select either a stamp or a draw and pick the color that you like. And go ahead and tell me what you see are the host. Can you identify any host?
While some of y'all are working, just a quick reminder to access the annotate feature. You'll go to view options, which is at the top of your screen, right next to that green box that says you're viewing Stephanie's screen. And click view options, and it'll give you the option to select annotate. And then the fourth option in from the left is the stamp feature. So you can use a stamp or the draw feature and identify some hosts.
Thanks, Dave. And it looks like many of you are doing a great job using that annotate feature and selecting the host being those people who are floating down the river. And so, you know, when we think about this scenario, there are a few things that really stick out to me. First, you know, it's a little unusual maybe to see all these people floating down a river. Is it? And so then if you see on the right, we have some helpers. We have some people who are obviously trying to help these people get out of the water. And you can see that there are some dangers lurking. If you look on down the river, we've got some rocks and then an apparent waterfall. And so it seems like we need to get these people out of the water pretty quickly, right? But then what's this person on the left doing who seems to be running away from the problem? Well, I would argue, that that is our coalition, because we have our hosts who are floating down the river. We've got the helpers who are jumping in to help them, but this guy's the coalition. Why is he the coalition? Well, because he's running upstream. He's going upstream to figure out what the problem is. Why are all these people in the water in the first place? And so what the coalition finds out is who the agent is or what the agent is. And the agent is pushing these people into the river. And so we can pull these people out of the river just as fast as we can. We've got helpers in our community. You know the doers in your community, but we can only do so much if people are continually creating this problem. And so the coalition is the one who's running upstream into the environment to identify the agent so that we can work back to that epidemiologic triad to where we identify the agent, the host, and the environment. And then we can work through comprehensive strategies to be able to address this problem that we identify. So if you give me a second, I'm going to clear all the annotations. There we go. And we're going to work our way through. I know that many of you are probably already pretty familiar with the strategic prevention framework. And so we're going to go just very quickly through this idea that the strategic prevention framework is our guiding principle. So really it gives us this roadmap approach that is somewhat systematic, but we also find ourselves circling back through these different pieces time and time again. So when I think about the strategic prevention framework, I don't think about this linear process where there's a start and a finish. Rather, it's the cyclical process where we as coalitions and community partners start typically with assessing the needs and resources in our communities. And then we build capacity around those areas. And then we're planning and we're implementing that work, and we're continuously evaluating, working around these two guiding principles of sustainability and cultural competence. And so when we think about the strategic prevention framework, coalitions are most successful when we continuously work our way through each of these pieces systematically throughout the lifetime of our existence. And so the purpose of the strategic prevention framework is multifaceted. One, it's to be dynamic and interactive, but also we want to be data driven. We don't want to just go and do things in the community that are expected or that feel good. We want to go and do things in the community that have purpose, that have outcomes that lead us to population level change. The strategic prevention framework also sets us up in a place to utilize evidence-based programs, practices, and policies to lead toward that successful change. And then it's also truly reliant on a team approach. So we could single-handedly sit down and do a community assessment, work on a capacity plan, come up with a plan and try to implement it ourselves. But that's where we would really fall short if we tried to do this solo. We really must, when we utilize the strategic prevention framework, incorporate all the members of our community. And this is where we hop into the middle of the strategic prevention framework around this cultural competence piece, because the mantra that I always think about in prevention work is nothing about me without me. We cannot plan for our people. We must plan with our people. And so that's the purpose of the strategic prevention framework, is to give us this platform to really engage our target population in our planning. And so the cool thing about the strategic prevention framework is that it's applicable to any issue or community problem that we may face where you live or where you work. And so we can apply this in many different areas. And so we're going to walk through each of the elements of the strategic prevention framework and think specifically about an opioid specific lens about how we utilize each of these phases. And so in the assessment process, we're really working to assess problems and their related behaviors. The assessment period gives us the opportunity to collect a lot of data so that we're making data-driven decisions so that we can then prioritize our problems in terms of magnitude or time trend or severity, where we might even compare some problems, and then we're able to assess the risk and protective factors that go along with those problems. As we do this, thinking about, excuse me, opioids specifically, we're probably in this phase going to be measuring opioid use and the consequences of non-medical use. So there would be a number of data measures that we'll identify a little bit later that we want to be collecting during this assessment phase, because again, we want to be making data-driven decisions. Once we identify those problems and have data to support them, we then want to build capacity around that specific idea. And so we think really when we're talking about capacity building, the reason we want to try to do our assessment first is because we want to engage in targeted capacity building. We don't necessarily want to just have this big network of people who are coming to a meeting to eat a turkey sandwich. We want to have the right people at the right place at the right time. And so in order to do that, we can then begin building capacity to engage those community stakeholders that we really need for that moment in time, so that we can have a really strong prevention team to affect the community awareness and the community readiness related to this specific issue. And so when we think about opioids, we want to specifically be thinking about people in our community who have access to both the data that we need, but also who are part of the infrastructure of how people are accessing opioids in the community. So be thinking about people like the medical examiner in your community, doctors, dentists, veterinarians, mid-level prescribers, even patients and insurance companies and businesses, because we've got to build awareness around the problem as it exists. And so maybe in your community, it's prescription opioids, maybe it's heroin. If it's heroin, then that might warrant bringing on law enforcement partners as well. And so we really want to be strategic in how we're building capacity and make sure that we're building capacity around the issues that we're targeting. So then once we, excuse me, once we engage in this place of we have the data, we have some capacity built around it, we want to then engage in some planning. And so again, we want to make those data-driven decisions to identify where we start and who's going to be part of doing that work. And so in order for us to be successful in this endeavor, we've got to prioritize those risk and protective factors. We can do that in two different ways, one based on importance or one based on changeability. And sometimes when we think about changeability, this ties into community readiness. Our community might not be ready to address a particular topic where we might have some low-hanging fruit with something else. And so these factors will come in as you're prioritizing some of the risk and protective factors in your communities. Then we begin to select interventions. And when we select interventions, this is where we want to identify interventions that are going to be effective, but also fit both conceptually and practically. And then once we identify these pieces, we then want to develop a comprehensive plan that aligns with our logic model. We're going to go into that into much more detail. That's really the crux of our conversation here today. Once we follow that planning piece, we then get to the fun part for a lot of people, that is implementation. And so this is the actual delivery of our programs and our practices that we've planned. And we want to be mindful during this phase that we're implementing with fidelity and we're balancing adaptations and retaining those core components. But we also want to establish implementation supports and monitor the work in our community. So implementation phase is really important because this is where we really see that true community collaboration. If we're doing coalition work right, then we're collaborating with community partners. We're meeting people where they are to implement effective strategies to achieve that population level change. But here's where coalitions get hung up sometimes, is coalitions are the idea generators in the community, right? We are the ones who identify the need, we identify the evidence-based practices, and then we find the people to do the work. But then sometimes in order to institutionalize those efforts or sustain those efforts in our community, we have to let those programs go to whomever's the most appropriate party in the community to carry those on into the future. And sometimes that can be difficult for coalitions to let go of. So sometimes as coalitions, we have to give ourselves the permission that and the grace to let that baby bird fly the nest. And sometimes that's the hardest thing of coalition work, because I see y'all sitting out there. You're just like me. You have that desire for perfection. You want everything done perfect and now. And sometimes when we pass that on and institutionalize it in the community, other entities might do it a little bit differently. And so I'm giving you permission now to recognize that that's okay. And that's our whole goal in coalition work, is to really spread these efforts across the entire community, across all of our stakeholders. And so once we implement, then it comes to that very important piece of evaluation. And this is where some coalitions kind of skip over or skip through the evaluation piece. But the evaluation piece is really critical because it helps us, one, to make sure that the data-driven decisions that we made correctly and we're using the right strategies to achieve change. We can do our evaluation, process evaluation, and outcomes evaluation. And if we do both, then we're able to recommend improvements and make mid-course corrections so that we make the most effective use of our time and our resources, which we know are oftentimes scarce. So it also gives us the opportunity to share and report evaluation findings. This is important for communities because substance use prevention it takes us a while to achieve change. And so we need to celebrate those intermediate milestones to make sure that we're engaging our stakeholders, that people feel like what they're contributing to is creating change, that we are not living in a hopeless situation and that we can do something about this. Also lends credibility to your coalition and to the work that you're doing when you have the opportunity to share those evaluation reports, and then also helps you to engage additional stakeholders in the process. Because as you remember, when we draw back to the strategic prevention framework, we're constantly working in and out of each of those components of the framework, and we're constantly building capacity. So we want to continuously engage additional people in our work. And then of course we want to sustain the work that we do. And as we're thinking about sustainability, if we think about sustainability in the planning phase, then it gives us the opportunity to plan for the long term. Recognizing that community change takes time, thinking about sustainability in our planning process gives us the ability to be adaptable and dynamic. The coalition's role is to make sure that we're the people in the community who continuously have our finger on the pulse of what needs are current and what needs are trending. And we can then rely back on the strategic prevention framework to ensure that those problems are both relevant, and then the work that we're doing is relevant to meet the needs of those problems. Also, in order to achieve sustainability, we want to engage the community members and partners throughout the strategic prevention framework. It's really easy to go out and identify people in the community to help you with implementation, but we want to get them engaged in planning. And we want to get them engaged in assessment and evaluation and sustainability and cultural competence in each of these pieces. When we identify community partners, especially thinking about opioids, we want to think about those people who can support the effective implementation for the long term. So who are those partners in your community? And then what's in it for them? We want to be able to clearly identify their benefit for being part of this solution. And again, ties into this idea of building ownership of our strategies among all of the partners in our community. And cultural competence might be one of the most important pieces of the strategic prevention framework, because if we don't include our target population in prevention planning, we can really potentially miss our mark. I want to pause here for a moment to give you an example of an experience that I had. And I was at a conference a number of years ago. It's been probably over a decade ago now. And I'm one of those people who I can't, as Carlton has already mentioned, I can't take any downtime. So on my lunch break at a conference, I'll typically hop up to my hotel room and sit in front of my computer and catch up on some work. And so I was doing that at this particular conference. And the gentleman who was servicing my room happened by every day about the time I was there for my lunch break. So we struck up a conversation, and his name was Sol. And Sol came to the United States from Madagascar, and he was here studying public health. And so we immediately hit it off because we were both people studying public health, and he had worked for the World Health Organization. So if you're a public health person, the World Health Organization is a pretty big deal. And so we talked about his work with the World Health Organization, and just ended up had a week-long conversation over lunch. And Sol was very interesting and shared with me a lesson that I carry with me every day that's so relevant to our work, because he was telling me about a project that he worked on in Mozambique. And so there was an extremely high rate of fecal-borne death in Mozambique. And so the World Health Organization went in and installed operational toilets in all of the residences in that community. When they left, they were monitoring the data, and what they found was the rate of fecal-borne death did not change. Well, why didn't it change? Because they didn't recognize the cultural reasons of why there were fecal contaminants in the water supply. Because what was happening in this community is it was part of their ritual, and it was a religious custom that the males in the community were not allowed to defecate in the presence of a female or a child. And so what happened was all of the males in this community had a spot where they went to defecate, but it happened to be really close to their water source. Mm-hmm. And so even though the operational toilets were installed in all of the home residences, the males didn't use them. And so the rate of fecal-borne death did not change. And had the World Health Organization gone in and included the members of the community in their planning, it would have been very easy to install some toilets where the males would typically go, but they didn't know because they didn't involve their target population in their planning. And so that story really sticks with me, and I try to remember it every day when I'm engaged in coalition work, because it's so critical that we go by that mantra, nothing about me without me, because we have to use the relevant and culturally appropriate prevention approaches based on the populations that we're serving. And so when we think about opioid use in communities, this is where we really must have a conversation about stigma. There is a significant stigma around opioid use, whether it be intravenous heroin use or non-medical use of prescribed opioids. There is a stigma associated with them. And so we have to be careful in our approach to, one, ensure that people who have legitimate pain are treated and their pain is treated. We don't want people to experience pain. We want to promote that there are non-opioid alternatives that are effective at treating pain, but we also can recognize that there are instances where opioids are a proper course of medical treatment. And so we have to be careful not to stigmatize any use of opioids. We just want to make sure that we are educating people and that we're culturally appropriate in our communities in the language that we use and how we address the problems that are at hand. And so when we think about cultural competence, especially related to the opioid crisis, we want to be mindful of person first language. And this is something that I believe ties really closely into our work anyway as prevention specialists. But person first language is where we're moving from labeling people as an addict or using the term addiction. And we're moving forward to a person first language where we are using more proper medical terms like substance use disorder or a person who is actively using an opioid. And so when we can make that shift in our heads, then it's better for the community and it helps us to reduce that stigma associated with both substance use disorder and opioid use and non-medical use of opioids. There's a lot of information out there about person first language. If this is the first time that you've heard about it, please make sure to look that up. There are some great charts that have terms to avoid and terms to use instead. And so that's not the sole focus of our conversation today. So I'll just refer you to some of those resources. And Carlton and or Dave, maybe we can pop some of those in the chat box. So I'd like to bring us to a point of discussion. And Dave, we're going to go to breakout session here. And I want you all to take the opportunity to have this conversation. And Dave is on top of things. He's going to put these questions in the chat box. And in the chat box, please refer when you get to your breakout rooms. We want you to have a conversation amongst yourselves. Have you ever used this strategic prevention framework to address opioids in your community before? And if you have, was it helpful? And what did you like about the process? What came of the process? If you haven't used it, how could you use this strategic prevention framework to address opioids in your community? This is a great opportunity for you all to learn from what some of your colleagues are doing in other communities, and make sure to take notes because we can borrow heavily from each other in these situations. I'll pause and see if anybody has any questions before we go to our breakout discussion. Okay, hearing and seeing none. Dave, we are ready to go. You all will have 10 minutes and you'll get a 2-minute warning when you have 2 minutes left in your conversation.
All right, hold on 1 second, guys. And
At least what I heard, some good thoughts shared with one another, and also helped me to recognize that everybody on the call isn't coming from a substance use prevention perspective. And so I'll try to make sure that I keep that in mind as I move forward. But I also want to engage in this conversation now because I want you all to feel empowered to unmute yourself and engage in dialogue today. Ask questions in the chat, or please unmute yourself and ask questions aloud as well. So before we move on, let me pause to see if anybody has any questions that you'd like to ask.
Stephanie, I'll just simply share one idea and thought, and that is, while we have a diverse grouping here, and a lot of folks, there are indeed a lot of folks that are working with coalitions. They may not be the leader of the coalition or the like, and in any respect, all of them are and can touch communities that are working with coalitions. And so this is a training that is intended to try to help those that are working with coalitions to think more critically about how to do that work.
Awesome. Awesome. Well, and having community partners like you at the table at a training like this is really the best case scenario for community level work. So thank you all for being here today.
One of the biggest challenges that came up during our breakout was simply the conversation around folks having to translate the strategic prevention framework, particularly with those in a rural context, and how do they engage and doing a lot of translation. And so that's where we got beamed back into the room. So those are just some of the undercurrent thoughts that we were kind of addressing.
Yeah, that's good to hear, and not dissimilar conversation where I was in breakout room 3, but also this idea where sometimes when the leaders of a movement like this move on to a different job, or there's some turnover and there's not as much support from an administrative standpoint, that sometimes things can fizzle out. And so I think that that's when the strategic prevention framework becomes really important, when we involve so many community stakeholders, because if enough people are involved, then we're able to continue that momentum despite some changes that may happen with personnel along the way. So just continue to be mindful of these ideas as we move forward. And again, please feel free to unmute or pop a question in the chat box as we move along. I want to move us now into some factors that lead to risk behaviors. And so as we do that, we talk, and I'll go through this very quickly, just about the risk and protective factor theory. And Hawkins and Catalano initially published research about risk and protective factors, but essentially the risk factors are those factors in the community that associate us with a higher likelihood of negative outcomes. And then protective factors, we can mitigate risk factors with that are associated with a lower likelihood of those negative outcomes. And so here's the thing. Everyone has risk factors in their life, whether they be biological, psychological, within their family, community, cultural risk factors. We all are exposed to risk factors. The most successful people are able to mitigate those risk factors with protective factors, or someone is able to institute those protective factors for them, where we counter those events that are risky and or reduce a risk factor's impact. And so we know that risk and protective factors are correlated, but they're also cumulative, and they can be associated with multiple outcomes. And of course, they're influential over time. And so we know that risk factors are positively correlated with other risk factors. And so the more risk factors a person is engaged in, they're likely to engage in other risk factors. But they're also negatively correlated with protective factors. And we know that those risk factors have a cumulative effect. And as we mentioned, they can be involved in multiple contexts. So with relationships, communities, or within society. And so we just want to recognize that protective factors can also be instituted at those levels as well, and can produce positive effects in multiple areas, just like the risk factors can have that trickle effect as well. And of course, can be influential throughout a person's entire lifetime. And we think about risk factors in the community, we're talking about availability of drugs or firearms, or a transition in mobility can also be a risk factor. But of course, the list is quite comprehensive. And within the family, there are risk factors as well, including family management problems, or history of problem behavior, conflict, or favorable parent attitudes for involvement in the problem behavior that you're looking at. And then, of course, risk factors within the school, such as academic failure or lack of commitment. Risk factors within the peer and individual can look like rebelliousness or antisocial behavior or gang involvement. early initiation of the problem behavior. I'm probably not telling you all anything that you've never heard or thought about before, but here's where I really want you to think about is, why do coalitions fail at achieving our objectives? And so sometimes we just have to say, well, why aren't we perfect? And sometimes it's because we say, well, people don't think using prescription medications outside of how a doctor prescribed is harmful, or there's no education on opioid use in school, or parents think it's okay to use prescribed opioids. However, we know in our heads, and we have the data to suggest that we can articulate local conditions that are specific, that are identifiable, that are actionable, that we can do something about, but we just don't articulate them in the right way. And so I encourage you to think about local conditions a little bit differently. So instead of saying, people don't think using prescription medications outside of how a doctor prescribed is harmful, let's say it a little bit differently. Let's be a little bit more specific and say, people save their unused opioids from previous prescriptions and they use them for backaches after doing yard work on the weekends. That's something that is specific, it's identifiable, we could see that happening in the community, and we could do something about it. Instead of saying there's no education on opioid use in school, let's say youth use opioids they steal from unlocked and unmonitored medicine cabinets at home after school before their parents get home from work because they're coping with anxiety. Instead of saying parents think it's okay for kids to use prescribed opioids, let's really get down to the who, the what, the when, the where, the how. Parents give their kids opioids after athletic injuries, which they share with their teammates to enhance athletic performance. So if we are able to be very specific about the behavior that's happening, then we can come up with a comprehensive list of strategies to be able to do something about it. And so we can use the why technique to ask ourselves, what does this problem look like where we live? We want to dig deep to identify the behaviors that we can see in the community. This gives us the opportunity to pull all these stakeholders together that we've developed through our capacity building to get agreement from that group and prioritize what we need to do moving forward, so that we're identifying something specific, something we can actually see, and something that we can change. So again, those local conditions tell us the when, the where, the who, and the why, or under what circumstances something is happening. And so I want to talk about how successful coalitions align strategies to their local conditions. And when we do this, we're really using what we talk about as a logic model. And so Carlton was talking about how sometimes it's our role to translate the strategic prevention framework to members in our community. And we don't have to use these big words like strategic prevention framework and logic model. We can say, we've got a plan that we want to follow, and this is our idea of how we're going to change things. And we can simplify things down to the level that people in the community need to understand. But ultimately, we want to start with a problem. And when we think about the problem, we want to break it down into what are the risk factors, or what are the root causes of why this is happening? And what local conditions do we see in our community that are the behaviors because these risk factors are existing in our community? When we think about the local conditions, this gives us the opportunity to really strategize in a specific way. And so here's an example of how we can really dig deeper into the behaviors that are happening in our community. So if prescription drug use among youth is the problem that we're addressing, we might have root causes or risk factors of social availability, maybe even community norms. But what we want to get to is, what does social availability look like in our community? And when we're able to identify that it looks like students selling their legally prescribed drugs to their peers, then we can come up with a set of strategies to do something about that. If we can identify that youth are taking medicine from medicine cabinets at home without their parents' knowledge, then we can develop strategies to do something about that. And so this is where those local conditions become really critical to identify as specific, identifiable, and actionable, so that we can do something about it. We can strategize for that. And so there could be a number of risk factors for opioid use in your community. There may be favorable parent attitudes or youth attitudes. It might be the community norm or the cultural norm. Opioids might be easily available to purchase through a retail outlet or through social means. There may be laws and enforcement that are setting it up to where opioids are easy to get and to use, or maybe the price and promotion is right, and that's what people can afford, and that's what people can get their hands on. Ultimately, we want to, again, be able to, if we pop back, you see that we have data mapped to each segment of our logic model. So our problem, our risk factor, and our local condition. And so when we're using this idea, we want to then map data to each of those components of the logic model so that we can begin to show that story. And that becomes the beginning piece of your evaluation plan, because we are able to then show that change. So where do you look for data in your community? Well, first, you might want to look into opioid overdose deaths. You also might want to look into non-fatal opioid overdoses. Do you have access to the number of naloxone deployments? What about prevalence of use? Do you have a student survey that tells you what students are using, how often they're using? Do you have a database that tells you the number of prescriptions per capita or the milligram morphine equivalents that are prescribed for pain? This list is just a starting point to launch you into data that are available in your community. Number of opioid use disorder treatment providers or provider perception of opioid seeking behavior. When we think about these data, we want to then identify who are the people in our community who have access to these data, and let's get them at the table, because again, you don't have to do this by yourself. We want to have this wide network of people who everybody can do a little something to the bigger picture. So we think about understanding the problem with respect to our data. We want to know about the consequences. Who's using? Where are they getting it? What are the perceptions that people hold about opioids in the community? And what are the costs to our youth and to our society? This gives us the ability to begin assessing community readiness and start thinking about how we're going to address that problem. And so very quickly, I'd like for you to, we're going to annotate again. So I'll remind you that you can go to the toolbar at the top and click View Options and click Annotate. And if you think about if we use an example of someone speeding, show me some of the strategies that would prevent you from speeding on this street.
Show you the problems that show you the things that what?
Please show me the things in this picture that might prevent you from speeding down this road. Yeah, y'all got it. There are a number of things in this picture that would prevent me from speeding. Now, I mean, Carlton and I both live a fast-paced life. I know Carlton likes to drive fast, and I do too. But there are things that are going to slow me down. So this speed limit sign right here might not slow me down. But I'll tell you what slows down Stephanie Strutner every time. Those speed bumps up there, because I don't want to spill coffee on my white pants, y'all. So when we think about this, we want to identify different strategies, because how many of you out there would slow down if you can see the speedometer there on the dashboard and it's going more than 25 miles an hour. So how many of you would slow down just by passing by that speed limit sign? Yeah, okay, I see some hands and I heard some people saying no. Yeah. How many of you would slow down by seeing the construction zone? Yeah, I see some people and some faces. Some people are like, yeah, maybe, and maybe not. How many of you would slow down because you saw the police car?
Definitely.
Oh yeah, okay, lots of hands. Thank you. I would too. How many of you would slow down just because you got a baby in the back seat?
Yeah.
Yeah, yeah.
Yep.
So here's the thing, we don't even have a lot of people on this call, right? But even among us who are good community citizens, who are in many instances rule followers, we still have different ideas of what's going to change our behavior. And so when it comes to our communities, we have to have strategies that are in combination and complementary to one another. We can't just think that we're going to put an orange cone by the side of the street and get somebody to stop speeding. No, we got to provide information by having that sign there. We also can build skills or enhance support. These are those individual level interventions that happen just within a person. We also can have those environmental strategies where we change access or change barriers or even change consequences, a speeding ticket, for example, or change the physical design of the environment or modify policy. And when we do these things, we're able to have this comprehensive approach to where we change that behavior. So, for example, if youth are sharing prescribed opioids with teammates to enhance athletic performance post-injury, if we just go into the school and say, hey, student athletes, it's dangerous to share your prescribed opioid medications with your teammates. How many of those student athletes are going to change their behavior, you think? Okay, thank you, whoever is laughing, right? We're probably not going to change everybody's behavior by just going in and telling them that it's dangerous, right? We've got to have this comprehensive list of strategies. So how do we do that? Well, just like the speed limit sign, we can provide information. So we might have signs in the locker rooms, and we might have a media campaign on TV, or we might have meetings with the coach and the team about the dangers of opioid misuse. Just like if you were caught going too fast on that street and that nice police officer caught you and gave you a little ticket, maybe it was your third ticket or your third donation to the city of Knoxville, and you had to go to driving school. Just like people might have to go to driving school to build their skills around how to drive the speed limit, we might also have trainings for student athletes and their parents and their coaches on non-opioid pain treatment alternatives, or offer continuing medical education courses for prescribers on non-opioid alternatives. We could also enhance support. Just like we have a speedometer on our dashboard, we could have a physical therapist to join the team at practice to make sure that the students weren't playing through pain, that they were actually treating the root cause of their pain, and have athletic trainers who monitor athletes who are not in good enough shape to train. Just like some vehicles have a governor on them, some of you identified and put a stamp on the governor on the dashboard of that vehicle. I must admit that my vehicle has a governor on it. My husband absolutely insists upon it. And just like we have a governor on the car, we could have appropriate physical therapy for students during practice when they are injured. So instead of them having the pain and just covering up, masking the pain, we're treating the root cause of their injury. We could change consequences. So, you know, those of you who identify that you'd slow down with the police car, we could also have similar options for youth who are sharing prescribed opioids with their teammates by offering non-punitive mandated treatment for students who are caught with opioids at school or athletic events. Changing the physical design, we talked about those speed bumps slowing Stephanie Struttner down every time. Well, we can encourage parents to keep their children's medicine in a locked and monitored cabinet in the home. Policies, we have a policy that if you go over the speed limit and you're caught, you can be fined. Well, we can also modify policies to collaborate with athletic departments to adopt non-opioid policies for student athletes. The point here is we want to be comprehensive and complementary. If we just identify one or two of these strategies, are we going to change behavior of everybody in the community? It's unlikely. We want to come up with this comprehensive set of strategies so that we can address change. We also want to recognize that our strategies complement one another. they work in collaboration together. And so we want to make sure that they fit in really well so that we can maximize our reach. And so finally, I want to toss things back over to you, Carlton, so you can walk us through how coalitions are creating partnerships to further objectives in this realm.
Fantastic. If you stop sharing your screen, everybody, I just want to say, first and foremost, if you feel like you can come on camera and like, please do so at this point. But can you use whatever activities or functions you have access to show our appreciation to Stephanie for a fantastic job. Anything that you might be able to do, please share your appreciation for taking us through that wonderful conversation. I was going to show and just simply kind of go through a showcase of actual community coalitions and what they've actually done so that you can see examples of all of that. What I think is more important right now is to provide some opportunity and space for questions that you all might have. And so if you have some thoughts, questions, some of you work with your coalitions, others of you don't work with coalitions, but this is all new information. This is all information that you might be able to use for your work and your efforts and your agencies. And so if you can't come on screen or do this by voice, please feel free to put some questions in the chat, but take advantage of the fact that you have me and Paula and Dave and Stephanie here. What questions do you have regarding some of the information that you've heard today? And we're going to provide about 5 minutes or so for Q&A.
Hi, I'm Jennifer DeGrees. I actually work as an eye care prevention specialist in Baton Rouge school system. And I have to say that I have been a school counselor and teacher for many years in a couple of parishes. This is my first year as a prevention specialist. And I know Dr. Harrison is on the line, and she will attest to the fact that myself, along with a few other newcomers in eye care, have been learning about the logic model and, capacity and, all the different things, coalitions, all the different things that Ms. Stephanie was talking about. And seeing her visuals on them really helped to put a lot of this information and this knowledge that I've been learning into perspective. Although I've never been a major, I am on some advisory, committees, but I've never actually been a huge part in putting together a coalition. But I will say that this information was very helpful in taking the information that I've learned and putting it into perspective. So thanks to you and to her and to everybody who put on, what has happened so far, just so that way I can learn more about it.
Jennifer, thank you so much for that comment. Appreciate that. Appreciate that. Thoughts, questions, guys. What thoughts, questions do you have? Please feel free.
Some of the prevention people on the line, they've been knowing me for many, many years. And every time I hear this information about opioids, most of them, and for the people that don't know me, I have two boys. One is 29, one is 19. And I always share my personal experiences, what I went with them. The 19 is cool, okay? The 29 gave me a lot of troubles. So when he pulled his wisdom tooth, like I think he was 16, the first question was like, what they gonna give me for pain? Mm-hmm. I'm like, oh, they're gonna give you a lot of stuff for pain. Don't worry about it, okay? So when we got home, I gave him 2 Tylenols. Okay. And he was like, oh, this is good, because he thought that he was getting opioids. No, he was getting Tylenol. Okay. He took Tylenol for 3 days and he was perfectly fine. The pain was gone and he was cool. So that was my motherhood strategy. I never gave him any opioid, nothing prescribed, and he was Very good. He was very
So,
good.
so Stephanie,
So at home, we can
have
use
to
those strategies and they work. They work.
Stephanie, you have to add to this, to the 7 strategies, and put lying to our children.
That's not lying.
Now, Carlton, we just call that the mama strategy, okay?
Okay, that's just, oh, I'm sorry. That's
Thank
right.
you.
That's right.
Yeah, or the daddy strategy, or whoever it needs to be. That's
Amen.
a parent strategy.
That's a parenting strategy, and that's what I want to share with you guys. That was like, you know, we collaborating here, so this works. I'm telling you. You give them 2 Tylenols, pain is gone.
Thank you very
Well,
much.
you know, Paula, the thing about it is and I've done a lot of continuing medical education courses in collaboration with physicians, and there are 4 pain pathways, and we know that opioids are only effective at treating opioid withdrawal pain and then emotional pain. And so the actual physical pain that we feel is best treated with a combination of NSAIDs and acetaminophen. So you did good there.
Amen.
Good job, Mama.
Amen.
Thank you.
Brother Banks, thank you so much for the comment. Appreciate that. I want to just share with everybody online. First and foremost, I care desperately about the work that you all do and in your state. I had the wonderful privilege of coming out and providing support and work out there, and then fell in love with the community members and the coalitions and the food. But I will tell you that this was the closest that we were able to get to coming back and being able to provide some additional support. I want these trainings to serve your purposes, your needs. And so I want to make sure that if you have some thoughts or questions that we can be of help, please feel free to share that with us. Let us know. We will incorporate some of that information in some of the upcoming training and training events as well as we do this, and also continue to use the chat. Dave, is there anything in the chat that we want to address before we begin to close the session out?
No, I'm not seeing any questions right now. There were some comments earlier about using logic models with the CCYS, but that is it for now.
I tell you, one of the biggest things that I know that many of you are working with and working through is how to ensure that you're taking this information and then bringing it to your people in ways that they can use it and can do it. And I always refer to that as doing that translation work that we have to do. You know, the context within the work that you all are doing, and it's all unique. And so we are also here to help you kind of think through some of this. Look at the tools and the skills that Stephanie shared as just that. They are tools to be able to utilize, but then you get a chance to be able to determine where and how you'll be able to present that to your folks. And so with that, I'm going to share my screen now. Excuse me.
Carlton, while you're doing that, I want to address something that Kitty posted in the chat box about how they've used logic models but find it challenging to apply the logic model.
Thank you. Please.
To the different cultures in the community. And so with respect to that, I think that's the coolest part about the local conditions is you could theoretically have one root cause, but then have lots of different local conditions based on the different cultures that exist in your community, and then be able to strategize out about those. And so might be something that you can think about moving forward.
Thank you for catching that. I missed that comment. And so, Dave, if you don't mind, place in the chat box the evaluation link, and those of you who are there, please take the time, capture that link. I will be providing a follow-up email after this training event you'll see pretty soon. We are indeed recording this training. Not your private breakout sessions, don't worry about that. None of that is going to be on the recording, but we are indeed providing the bulk of the training as a video to you all that we will provide to the LCPR for your purposes soon. So you'll be looking out for an evaluation for us. The evaluation will be open until Tuesday, close of business Tuesday of next week. And so please just try to do it. It takes about 5 minutes of your time to kind of work through that. So I will appreciate that. I want to make sure that you all are aware we will be coming back again on April 30th for our third session, environmental approaches to alcohol and other drug problems. So we will have a wonderful conversation with and around that. So we're looking forward to that. That will again be same bat time, same bat channel. Here you'll be getting all the information with respect to that. Folks, I just really want to give a sense of the fact that we are indeed living in what I refer to as urgent times, requiring all of us to raise the level of our state of play. The work that you're doing is so profoundly important, and the continuation of that work is so profoundly important. And we're doing all of it within the context of the times that we are living in. And so there is a real urgency to us attending to building our capacities and our skills. And so I do not take it for granted that you decide to use this hour and a half and spend your hour and a half of valuable time with us and through this process. I want to thank and offer my thanks to the great team. Dave Clausen, thank you so much, my friend, for all your great work and support. Stephanie Strutner, for your great work and helping us to pull this together in a fantastic presentation. Thank you so much for your support and for your friendship. I really appreciate you. To Felicia Johnson, Amber Slater, I don't know if you guys are on from the state, for your great leadership and the foundation of all that you all doing. And of course, Drs. Tolbert, Harrison, and my dear friend Paula from the LCPR, thank you for what you are doing. Paula, I am going to turn it over to you for you to have the last word with respect to that. And just offering my thanks. So Paula, you have the last word.
Thank you, Carlton. Thank you, everyone, for coming here today. I hope that the information that was provided wonderfully by Stephanie and Carlton really going to help you guys through your work in your communities. We are here to provide any assistance that you need. It's Friday. I hope you have a great weekend. Look forward for the evaluations that are going to come to your emails. Please fill out those evaluations. And Carlton shared the flyer on the screen. That flyer is available on the website for the upcoming events. You can register through the website. The LCPR will be sending emails with the flyer as well. So look out at your emails and register. Feel free to share the flyer with your partners, with everybody that you work on the field in prevention. If you have any questions about your CEUs or anything regarding the trainings, please email me. And like I said, it's Friday. Thank you, Stephanie. That was a great presentation. Thank you, Dave. Thank you, Carlton. I see I have Leslie and Felicia on the call. Thank you guys for all the support with the LCPR. And we're done.
Thank you so much, everybody. Take care and have a blessed weekend.
Thank you.
Goodbye,
everybody.
Bye-bye.
Bye.
Dave, you want to help us out?
Yeah.